Hey guys, Scott here of the Gait Geeks, and I'm going to be joined in a second with Ivo as well. And today we are going to be talking about posting, to post, to not post, where to post when making an orthotic are the questions we're going to be discussing today. So Ivo, how you doing?
Doing good. I heard you guys just had a little bit of water down there in Florida.
We had a lot of bit of water, but hopefully these hurricanes will stay away from us for a little bit. But we did okay in Central Florida, unlike some of our counterparts on the west and east coast, and even a little bit further south recently. And then a couple of weeks ago, northern Florida on the west coast, got hit pretty hard. So last couple of weeks in Florida have not been great. So how are you in Colorado?
You know, Colorado is high and dry where we are. It's getting cold, though. Where you live at 10,000 feet, just about. Actually, 9,000, just a little over 9. It's fall is pretty much over. The trees are starting to lose all of their leaves, and it was 24 when I ran the dogs this morning. So,
For those reasons, I am happy to be in Florida. As long as we can kind of push those hurricanes and tornadoes away, we're good. But
yeah, there you go.
today is a bright, sunny day with a little bit. I'm going to say a little chill in the air. Where I'm saying like a long sleeve shirt would be great, not like your chill where you've got to wear stuff to cover your ears, your neck, and all that good stuff. So
Yeah, it's still good though.
no gloves here. That's right. So we just had a recent seminar, Ivo and I, and it was all about orthotics, talking about how walking and running gait are influenced, or orthotics are influencing the walking and running gait, and if we have certain pathologies, how we want to use orthotic intervention and orthotic therapy as a tool to help assist us with our management. And the question came up as to the best places to post. There's a lot of we'll call it discrepancy or even lack of research out there as to truly identify what is and where is the best place to post when dealing with orthotics. There are some in the Forefoot camp, and then there are some also in the Rearfoot camp. So we'll give you our 2 cents. We'll talk a little bit about what the literature has to say and dive into that further. So, Ivo, how do you want to start this?
Well, I think first of all, why are we posting in the first place? So
Good
posting
question.
traditionally is thought about to control subtalar pronation. So in other words, we have a little too much pronation. So remember that pronation is dorsiflexion, eversion, and adduction, abduction, and supination is plantarflexion, inversion, and adduction, adduction.
Mm-hmm.
So when we have that and we have pronation occurring, why don't you bring up a slide of the gait cycle here? We can look at that real quick.
You want the gait cycle one? I was going to bring up what happens. All right, here's the gait cycle.
So when the heel hits the ground, we're looking at the left side here. So we got stance phase and swing phase. Stance is about 60, swing is about 40. When the heel hits the ground, hopefully the calcaneus creates enough friction with the ground that it stops. And when that stops, what happens is the talus starts to slide forward. The talus plantarflex, adducts, and everts. And what happens there is that causes medial rotation of the lower extremity, and that motion serves to unlock the calcaneocuboid and the tailumbicular articulation. So they're parallel. So you can bring up that slide, Scott. There we go. So on the we have neutral in the middle. That's when we first hit the ground, when we're traveling through the air. Supinated, when we first hit the ground, we can see those axes are approximately perpendicular to one another. And then as that talus slides anteriorly on the calcaneal facets and plantarflexes and adducts, those axes become parallel. That unlocks the joint and makes the foot into a mobile adapter. Making that foot into a mobile adapter helps us to absorb shock. So pronation is a good thing. It helps to absorb shock along with dorsiflexion of the ankle, flexion of the knee, drop of the contralateral hip. Those are some of the shock absorbing mechanisms that we have. So we don't want to stamp out all pronation because we need a little bit. And if we don't have pronation, that's just as much of a problem as if we have too much pronation, but causes a different set of issues. So traditionally, when we post orthotics, bring up the slide with the foot and then the separate calcaneus next to it that has the sus there. There we go. Perfect. So when we're looking at feet here, we've got a calcaneus on the sort of the closest to you, and then the whole foot furthest from you. You can see that little shelf underneath the talus. That's called the sustentaculum tali. And when I was learning all about posting and stuff, I was always taught control from the rear foot, and then the forefoot can kind of do whatever you want. So when we build orthotics, and I think when Scott builds orthotics, we post underneath that sus to try to control the rear foot. If we move the post anterior to that, it's under the navicular. If we're under the navicular, then we rotate the transverse tarsal joint in the opposite direction, and we don't get a lot of rear foot control, which sometimes can still allow pronation to occur. And when we have just in the forefoot, we can have that situation, as well as moving the axis of rotation of that distal first MTP joint dorsally and posteriorly, which can limit hallux dorsiflexion. So this is kind of what Scott and I have taught, and this is what I've been teaching for years. So we dug into the literature a little bit to kind of see what was out there, and it was a little surprising that there's not a lot out there. We found one paper that looked at 3 different kinds of posting. It was done in 2004. I don't know if you want to bring that up, Scott.
Let me see if I can find that. Keep talking. Let me see if I can bring that one up.
So anyway, what they did is they looked at 3 different conditions. They looked at rear foot. They looked at no posting. They looked at rear foot posting. They looked at forefoot posting. And then they looked at a combination of rear foot and forefoot posting. So I guess 3 posting conditions in one control kind of condition. And then what they found in this particular study was that if you just posted in the forefoot, really didn't control subtalar pronation that well. If you posted in the rear foot, or the rear foot and the forefoot together, you were able to control subtalar pronation to a greater degree, but there was not a significant difference between posting the rear foot by itself and the rear foot forefoot condition.
And if you think about it, when the foot hits the ground in that inverted position and the lower limb starts to move forward and you start to unlock, like Ivo said, the medial aspect of the first MTP shouldn't even be really close to the ground at this point. So how are you controlling any of that motion when pronation starts to be initiated with just a forefoot post? So to me, that's where that kind of bears the difference, right? And that's where the substance that we kind of go by with regards to controlling the rear foot kind of comes from, right? So if you were to just post a forefoot, you're going to get some calcaneal eversion. It's going to happen. Not that that's necessarily a bad thing, but if you feel like it needs to be controlled by just controlling the forefoot, you're not doing an adequate job of that. So there may be some cases, and I'm not saying forefoot posting is all bad. I think there are definitely some cases in which it can be very, very appropriate. But I think, and I agree with Ivo in that controlling the rear foot as the gait cycle is initiated really gives you the maximum bang for your buck. Some questions may lie, and again, I'm going to throw this back at Ivo here in a second, whereas let's say you're a runner with a forefoot contact pattern, therefore you may get a little bit more benefit or a little bit more bang from your buck by posting the forefoot as opposed to the rear foot, because the rear foot contact in a lot of cases in a true forefoot contact is mitigated some. So I don't know if Ivo has any thoughts on that either.
You're spot on, Scott, as far as that goes. When we have a forefoot strike pose method running, and even in cyclists, the forefoot is what's contracting the ground first. So if you have a true forefoot varus, or we'll say a true forefoot varus, where we can't get the forefoot is inverted with respect to the rear foot, you don't have enough motion in the distal first ray to get that down to the ground. By propping up that first ray and giving it a shelf or a step to rest on when we're striking on that, or if we're cycling during power strokes, or we're going from 12 o'clock to 6 o'clock coming down, that post can be critical to prevent 1, overpronation in the forefoot, and 2, medial knee fall, which can cause abnormal patellofemoral tracking. So absolutely with that type of posting there, we have not seen good forefoot control in rear foot posting with situations where people are only using the forefoot. So again, those particular kinds of runners and cyclists, because we've tried it. We've done the stuff in the office, and we've done that to those folks. So that can make a big difference. And then the question becomes, well, do we post just under the first, or do we create a varus post for the entire forefoot on that side? So what's the correct answer to that? The literature doesn't say, as far as that goes. What does logic dictate? Well, depending upon what the motion of rays 2, 3, 4, and 5 are, with respect to one would probably determine whether you're going to post the entire forefoot or if you're just going to post like a Morton's toe extension or something like that, just on the first ray. In cyclists, I tend to put a varus wedge in. We can put it inside the shoe, or we can wedge the cleat if it's an SPD type situation, or sometimes in the triplanar, road cleat. We're not talking like a speed play, but we're talking like a standard 3-prong pedal in the bottom. With runners, same idea. I have a tendency to usually post the entire forefoot rather than just that first ray. And again, depending upon what they're going. If they have a plantar flex first and that's rigid, and you go post in the forefoot, now you're going to create all kinds of problems as far as what's that going. And we're looking then at doing like a reverse Morton's or something like that, and basic or first ray cutout to maintain that first. Yeah.
Yep. So it's interesting. So in what we're talking about, if we control the rear foot, elevate the proximal aspect of the first met, that drops the distal aspect of the first met, which is ideally what we're looking for. If we're too aggressive distally and not as aggressive proximally, you're actually creating the opposite effect. You're actually dropping the more proximal aspect of the first ray, and thus maybe making the arch support or the arch itself not be as elevated as it may require. But if we can control the rear foot with a rear foot post, or control the foot rather with a rear foot post, then we can see, is the forefoot able or not to make medial contact with the ground? And if it has the mobility to do so, we may in fact do the exact opposite of what we were just previously talking about, which was medially posting. We may laterally post the forefoot to facilitate getting that first MTP to the ground, to again balance that foot a lot better. And I know Ivo is a big believer in that, and I am too. There's different schools of thought out there, but again, by controlling the rear foot, you elevate the arch, and then you see if the foot gets to the ground or not. And if it doesn't get to the ground, the medial aspect, the question is, does it have the capacity to get to the ground with a little bit of help? And if that little help is a little bit of a lateral wedge that drives the forefoot down, then by all means, that is an ideal position to get the foot into.
Yeah, what are the mechanics proximal to the foot too? You have to look at that. So the foot could look great, but if all of a sudden now they're getting a lot of medial knee fall, it may fix one problem but create another one. So now they go out for their run, and now they're getting patellofemoral discomfort or potentially even hip discomfort, because that's going to accelerate how fast the pronation is occurring. So if that pronation is occurring too quickly, we need to dampen that. If I can't dampen it at the ankle through sort of like musculature that's going to slow stuff down, like tib posterior, I think of flexor dig longus, flexor hallucis longus, then it has to occur at the knee, right? Popliteus. And then if it can't occur there, then it moves even more proximally. And we're talking about the deep six, quadratus femoris first, and then usually in my experience, obturators or gemelli, piriformis at times as well, just has less mechanical advantage being the most proximal one up in the hip area there. Occasionally I've seen one or two cases where glute max is doing the dampening, but it's pretty rare as far as that goes. But yeah, definitely something to think about. There was another paper, if you can bring that up real quick, Scott, that came out. This was much earlier than the 2004 paper.
Which one are you talking about here?
The one with an N. The Nowozensky paper.
Yeah, let me see if I can get that for you. Hold on one sec.
Yeah, so in the Nowozensky paper, what they did is they looked at individuals, and they looked at, and it's a little deceiving when you look at the title. They looked at people that had an arch type orthotic, they called it. And the arch type orthotic had an arch, but they put the apex underneath the navicular bone. And in addition to that, they did a rear foot varus post. In the forefoot posted orthotic, they did an extrinsic rear foot varus post in addition to a forefoot varus post. And then this is the one right here, yeah. And then they had another condition where there was no orthotic. And what these folks were looking at is not subtalar pronation. These folks were looking at the amount of hallux dorsiflexion that occurs, which is super important. So you can do this simple experiment at home, take a friend, a patient, whatever. They're facing you, their feet are facing you. What you want to do is press up on the bottom or the distal aspect of the first ray, that MTP joint, and just push that up towards their head, and then try to dorsiflex their hallux and see how that's limited, and then plantar flex it, put your finger under the proximal portion, bring that down, plantar flex it, and then check the dorsiflexion. And 9 times out of 10, it will increase the amount of dorsiflexion. So if we are raising that distal end of the first, like Scott was talking about before, we're going to move that axis of rotation backwards, and we're going to limit dorsiflexion. If we do that long enough, people will start to develop a little exostosis, a little bony prominence over the edge there. So first it's functional. We call that functional hallux limitus. And then over time, we'll actually get bony changes. And eventually, they'll have hallux rigidus, and they won't be able to dorsiflex their toe at all. And we talked about this quite a bit at the seminar and talked about some ways around that. And soon, you'll be able to go to our Vimeo channel if you're interested in that, and you'll be able to actually pull that specific lecture and watch that if you'd like to.
Yep, I agree. And another thing that I always love hearing you talk about is, the internal tibial torsion and the effects that it has on posting. So why don't you dive a little bit deeper into that? Because we know that, with a internal tibial torsion, the foot rests in somewhat of that inverted posture in the forefoot area. So what are your best strategies for dealing with that?
So internal tibial torsion means that when you drop a plumb line from the tibial tuberosity and you're dropping it down, it should pass through the second or between the second and third med heads. Okay, that's what we're looking for. And it has to do with in utero positioning of one foot over the other. Usually left is over the right. So we're born kind of dink-toed and bow-legged, and then that's supposed to change as we age. The foot is supposed to rotate out at about 1.5 degrees per year from age 2 or 3 till about age 15. Most of that growth spurt occurs between ages 3 and 6 that we're going to see. A lot of times it doesn't rotate out, so we're left with, if our knees are straight, our feet are pointing to the inside. So if we point our feet straight ahead, our knees point to the outside. If I take a traditional orthotic, or even an orthotic with posting underneath the sus, that's going to externally rotate, raise the foot up, and push the knee further out into the sagittal plane. If we do that, we're going to create a patellofemoral problem, and they're going to have knee pain and knee issues. And you'll also cause binding of the meniscus because we're not getting enough pronation occurring. Remember, we need just the right amount of pronation, right? It's not too much, it's not too little. It's the Goldilocks kind of syndrome. So what we want to do, sometimes people can compensate for that in their rear foot, because that's our main compensation area there, with calcaneal eversion. So if we get enough calcaneal eversion, we get the first to the ground and the knee can be in the midline, then the world is a good place and we can move on and run. But more times than not, the calcaneus doesn't evert enough. So what we can do is we can apply what's called a valgus post. We put a post on the outside of the orthotic, pushing it down. Looks like a big old triangle on the bottom of the ski. It's ground to 0 under the first MTP, and it's left full laterally. We have to be careful in making sure that there's enough motion in that first MTP that they can get it to the ground. Otherwise, what's going to happen is I'm going to create drive of the knee medially, which can create patellofemoral problems as well. So do they have an adequate amount of motion in there? And that's how you determine the thickness of your post under the first met. That's super common, though. And if you stick people that have internal tibial torsion, they don't have the right amount of motion there, in a valgus post, over time you will trash their meniscus. You'll macerate it. They'll come in and it'll be a subtle thing that'll occur over months to years. But then all of a sudden they'll be needing a knee replacement or knee surgery because of that. So be real wary of that. How much range of motion do they have? We spent a lot of time talking about how to determine that first range of motion, and also how to post and correct that. And we actually had participants going in and performing some of that. So Scott, why don't you talk us real quick how you assess first range motion?
So what I like to do is I like to my personal position is prone. I like to do it prone. I like to basically look straight down the barrel of the gun, so to speak, looking straight down from the rear foot into the forefoot, and basically locking that foot in what I would classify as a neutral position, and just seeing where the first lies relative to the second, third, fourth, and fifth, right? And so in the case of a plantar flex first, it's going to lie in a slightly different plane than the other four toes, and it will lay obviously a little bit more. I'm trying to look at the relative way to describe this. It will be more inferior relative to the plane of the other four toes. And then what you do is you try to see if you can manually move that first ray either in line with the other toes or beyond the plane of the other toes. And that will help dictate whether or not you've got a mobile, a rigid, or a flexible, or mobile, or a rigid or a limitus type of situation with that first ray. So it's all relative to the position of the other planes of the other toes, and where it sits in its quote unquote neutral position.
So you're kind of dorsiflexing the foot up. I noticed in the seminar you like to grab really distal. I usually grab the tail of the fifth.
I
And
do.
then what we're doing is we're just dorsiflexing the foot until we start to meet resistance. So we're pretty much engaging that calcaneocuboid locking mechanism and then checking how much that first is moving into plantar and dorsiflexion there. Yeah. The big thing we got to be careful of there when we're checking that, and Scott pointed this out a lot in the seminar, is just that if you push too hard, everybody looks like they have a forefoot valgus because you're just pushing the foot up into too much eversion in the forefoot there.
Correct.
Did you have any other comments on those studies, Scott?
No, I thought it was very, very interesting. And again, I think you've got to also consider whether or not, the forefoot is a compensated or an uncompensated. We talked about the compensated variety in which the medial aspect is able to get down to the ground. But in the case where you've got a forefoot varus that is rigid and uncompensating, you may have to be aggressive and bring the ground up to it. And that would really warrant a medial post in the forefoot. So I'm not, like I said, I'm not saying that a forefoot post is without need. There's definitely a case or several cases where it may be appropriate, like I've talked about with the running pose, forefoot running, those type of things, not uncompensated forefoot varus. Again, not all feet are created equal. Not all gait mechanics are created equal. Not all activities that people are doing are created equal. So you need to look at all of those different situations and see what is best needed for that particular individual based on what they're going to be required to do. And so it's I wish we would have a very easy equation. 1 + 1 = 2, or 1 + 1 = forefoot post on the medial side, or vice versa on the rear foot. But I think in most cases we tend to lie with controlling the rear foot, seeing what happens at the forefoot, and then again address the forefoot based on the mobility restrictions or the mobility characteristics that they have in the forefoot, as well as their alignment and other type of situations they have presenting with.
So what's been your experience, Scott, with people that come in with an orthotic, okay, and the orthotic, let's just say, has forefoot posting for some reason, but it's not a very aggressive type orthotic. In other words, the arch looks pretty small, like it's not probably going to hurt anybody, but it may not be helping anybody as far as that goes. So what's your experience with that, and then kind of your fix, and then we can talk about, I know what I would do, but.
So I think it depends on, so why are they coming in, right? Are they just coming in because they feel like their orthotic is worn and they need a new one? Because as we know, orthotics do break down over time, right? And they don't feel the support in their arch nearly as much over time because it does flatten. And sometimes we talk about orthotic therapy. They're basically doing their own orthotic therapy because the arch is starting to break down. They're not getting as much control as they previously had, and therefore they're using their foot muscles a little bit more. So they're basically weaning themselves out of their orthotics themselves by having an orthotic that's somewhat less supportive than it used to be. But if they're having pain, I think you've got to address again, how much control do they have, and where is the control being imposed? Is it being imposed based on the post? Is it being imposed based on whether the post is rear foot or forefoot? You mentioned forefoot in this case. I know we've oftentimes talked about using a heat gun and reheating the orthotic and lifting that up underneath the sus a little bit more. And then what I can sometimes do is actually put in a little bit of arch fill, which is basically filling in the inferior aspect of the orthotic shell with additional material to reinforce it, to help keep it elevated, so that when the body weight comes down, it sits in the vamp of the shoe a lot better. So there's more support from the vamp pushing into the orthotic arch fill into the shell of the orthotic, and then you use the heat molding aspect of it to kind of reinforce or remold the areas that you're looking to control.
Yeah, pretty much same. We do a test. Ed Glazer, I remember when I had taken one of his seminars a long time ago, describes this test called the Fowler test. So you have the patient stand on the orthotic, and when they're standing on the orthotic, you have them basically dorsiflex the first MTP and bring it up, and then you bring the orthotic up in the back to sort of simulate as they're coming through mid-stance and going through terminal stance and pre-swing, does that orthotic hug the arch or not? And if it does, good, and if it doesn't, then it may be insufficient. So again, we'll do just like you do. If it's heat moldable, we're going to mold it best we possibly can. So we've done that quite a bit, and you can take something that's not so good a lot of times and make it better. Of course, you need a deep enough heel cup for the calcaneus to bump up against when it inverts, except if they have a true rearfoot varus, and they don't evert at all. But we need enough of a cup there. Otherwise, what happens, we pick the arch up and they just slide off of it, on the rear foot, and then they bang into the side of the shoe. So if they got a nice tight heel box, maybe that's going to work. But in a lot of times, that's not the case. No, it was really good. We've got a lot of this stuff on video and a lot of these things that we're talking about. And again, that'll be forthcoming on the Vimeo channel. We're waiting for all the video to kind of get crunched down by Steve-O and Josh. So
I was also going to say, you can also add like a scaphoid pad to the arch as well to hit it from the superior aspect to create a little bit more arch contour and to again lift up the rear aspect of the arch, or the more posterior aspect of the arch underneath the sus to assist in that. So whether you're coming from the bottom, remolding it, or just artificially adding another pad like a scaphoid pad to create the arch, both are different ways about doing the same type of thing.
And sometimes that's a great test to see is a recast here going to really be helpful for this patient and what's going on? Do we need to do a rebuild, or do we just really need to be doing a bunch of other stuff there? And of course, Scott said this up front, it's orthotic therapy. It's not set and forget. We don't just put them in a pair of orthotics and see in a year. It's more like we are checking them. We try to do people, we do it at a dispense. We do a 2-week follow-up, a 4-week follow-up, a 3-month follow-up. And then at that point, we usually recommend a yearly follow-up. We don't usually charge for the follow-ups. It takes a few seconds to kind of look at it, watch them walk in it, look at the wear patterns on the device, see what that is. But if they are doing their homework and you are doing your job, their script should become less and less. So eventually, hopefully, they don't have to wear an orthotic. And that's kind of that's our end game with a lot of stuff that we do. So
correct.
Awesome.
And again, in a lot of my cases, my athletes are just wearing their orthotics when they're doing the sport that they're playing, right? So whether I'm dealing with a football, they're not wearing them a lot of times they're not wearing them in their normal shoes or what have you. Sometimes they are, but not all the time. So if they're just wearing it for when they're doing their sports, it's they're almost creating a situation where they're keeping their foot strong in one case and protecting it in another. So just different aspects.
So here's one other quick thing, Scott, just a question for you. I already know the answer, but for everybody else here. What do you think about the whole concept of, I hear from people that, and I would call us orthotic advocates, but we're not fanatics. It's not like the world needs an orthotic if they have a foot. It's more like we give you the mechanics that you don't have. What about the whole adage that you hear from people? And this is an argument I get a lot of times from people. It's like, well, I hear that they make your feet weak. Yeah. So how do you handle that?
I have a big soapbox that I can get on for this whole topic, but just like anything in the gym, right? If you're working on your biceps, you don't work on your biceps 24/7 to keep them strong. You work them out, you get them fatigued, you let them recover, they kind of rebuild, and the recovery process allows those muscle fibers to come back and come back stronger sometimes, right? It's that recovery that really is important. If you keep beating down tissue, it's never going to have the time to rebuild. So from my standpoint, with regards to orthotics, you use it when you need it. You don't use it when you don't need it. As long as you're spending time working on foot strength and control, I think that is an important characteristic that a lot of people neglect. I don't think you need to be working on foot strength all day, every day. I think there's times where maybe you wear your orthotics or you don't wear your orthotics for the beginning of the day, and then you kind of do for the second half of the day when your foot's fatigued. So there's different ways in which you can implement an orthotic to do the job you need it to do. I'm an advocate of foot strength. I'm an advocate of good normal foot alignment. I'm an advocate of a wide toe box shoe. I'm an advocate for toe spacers. I'm an advocate for the importance of trying to be as quote unquote natural as you possibly can with a lot of your shoes. I believe that sometimes cushion can be a detriment. I believe that the shoe ground interface should only be as thick as you really need at that given time. And that's going to vary depending on, again, body weight and a lot of other different factors. But so big believer in foot strength, big believer in a more natural type of environment. However, there are times in which we need tissue to rest and to recover. And in my world, as somebody that deals in the sports medicine population, If I have an injured piece of tissue in one of my athletes and an orthotic is going to allow me to rest that injured piece of tissue, and I use the term all the time, shift the load to another piece of tissue that can better deal with it and allow my athlete to perform and get on the field or the court with less discomfort quicker, then I'm absolutely going to do that. There is no reason why I wouldn't use that particular tool that I have in my tool belt to facilitate getting my athletes back and performing. I always say we have two jobs as sports medicine clinicians. It is to keep our athletes performing at a high level safely, and to get those that are injured back as quickly as we can safely. And an orthotic, like I said, is an amazing tool to do that. You break your arm, you're put in a cast, right? You come out of the cast, you work on your strength, your range of motion. You don't need the cast anymore once that's the case. However, while you're kind of regaining some of that, you need that protection. While that bone is healing, you need protection. And oftentimes we have injured tissue that need that protection, and an orthotic is that means in my hands.
Well said. So I want everybody that's listening to this right now to contract your plantar interossei on your right foot. Okay. And if you can't do that, do your adductor hallucis. All right. The point is, there's very few muscles in our feet that we can isolate, and conscious control over that is important. And we can do things like toe yoga and stuff like that, which are going to help to isolate some of that. But these guys, if you can't control it, what does that mean? Most of its innervation is not corticospinal. Okay, it's vestibulospinal when it's coming down. So they're unconscious that's working. When do your foot intrinsics that we're strengthening with all of these exercises, or a lot of these exercises, when do they fire? They fire from mid-stance to pre-swing. They don't fire when the foot first hits the ground, at least from the EMG studies I've seen. And if you've got one out there that says otherwise, please send it to me, because I want to be educated on that. But they're firing then, and you're not consciously control it. There's things we can do, hold our toes up, okay, fire into our extensor pool, things like that, which are going to assist this, but they're largely non-volitional muscles, just like your multifidus and your rotatories, which help to control stuff in your C-spine or your L-spine. So training them is important, like Scott was talking about, and we can hypertrophy them and we can strengthen them. But the whole idea is we're trying to create subconscious competence here, not conscious competence. If you only feel good when you hold your toes up, that's great if you want to hold your toes up for the rest of your life. It's like Ondine's curse, right? Where you have this theoretical brainstem lesion that interferes with your breathing center. So you can breathe volitionally, but the automatic portion is off. So if you fall asleep, you die, right? So you can never fall. It's the same deal, okay? We want to create competence in this musculature that can be there, so we don't have to consciously be thinking about it all the time. The exercises, the balance, all of that stuff is going to help. But we also need to understand that you can't, your brain may not work that way all the time. And the orthotic is just going to help you to have some of those mechanics for a while hopefully you're training, your patient's training, trying to get that back to where it needs to be.
I can't believe I went on my little soapbox without saying, and I agree 100% with what you just said, but I went on my little soapbox without saying the phrase that I probably said 100 times during our course or seminar. It's all about stress and capacity, right? It's all about allowing our tissue to have the capacity to deal with the stresses that the body is imposing on it, whether that's volitionally or autonomous, whatever it may be. The stresses need to be controlled via your tissue capacity. So the strengthening helps with the capacity, but the orthotics can also help decrease the stresses and allow your gas tank to somewhat fill up again so you can tolerate more. So yeah, there's a lot of different ways to kind of look at this and to decide whether or not an orthotic is appropriate or not. But again, it's not, if all you have is a hammer, everything's a nail. It's not as blunt as that. It's very much a tool that can be implemented strategically to allow you to perform activities that you need to perform throughout the day.
Definitely a tool. That's the way we like to think of it. That's the way we explain it to our patients. Now, some patients don't want to do the exercises. They don't want to do the strengthening. They don't want to do the work. And that's okay. The orthotic helps them out. There'll be a point at which it won't anymore. And we try to emphasize that fact. But you can't make somebody do the exercises that they should be doing. Fortunately for myself, as well as Scott, we work with a lot of athletes and people that are extremely motivated to get better. They don't really need something else that's extra weight inside of their shoe to get them to be able to do it. And they understand that this is just kind of giving them the stuff that they don't have.
Yep. No doubt. No
All
doubt.
right, cool.
Well, this was great, guys. So again, we're going to have some more seminars out there where Ivo and I both believe that in order to understand what you're doing, you got to get your hands on it, and you got to play with the materials. You got to play with the grinder. You got to play with all these different posts we're talking about. So our courses and seminars are very interactive, very lab based. So hopefully you can join us at one of our next ones. We're also going to have some on-demand type of stuff, like Ivo mentioned previously, where you can kind of get a handle as to what we do, why we do it. But if you're looking for the hands-on experience, we definitely offer those as well. So stay tuned to thegeeks.com, where we'll be announcing, as well as Instagram, we'll be announcing our upcoming seminars. And if you're interested in hosting a seminar, please feel free to reach out to us as well. We'd love to come to a town near you.
Yeah, message us and we'll help you out. Take care.
Thanks, guys.